Thank you so much. And with this, I invite our next and last panel for the day that will focus on facial augmentation mastery, discussing aesthetic outcomes through successful case studies. I would once again like to invite Dr. Apratim Goel, CEO and Medical Director, Cutis Skin Solution on stage as she will be moderating this session. Joining her on stage is Dr. Soma Sarkar, dermatologist and aesthetic physician, Dr. Soma's Aesthetic Clinic and Academy, Dr. Sonia Tekchandani, Dr. Sonia Tekchandani, co-founder and medical director, Tender Skin International Mumbai and the Wedding Clinic Pune, Dr. Chiranjeev Chabra, chief dermatologist and director, Alive Wellness Clinics, and Dr. Ashish Dhaval Bhakta, chief aesthetic plastic surgeon and managing director, Aesthetic Medi Spa. I have been personally requested by Dr. Apratim to not give a further introduction to this, just if all of you were thinking there were no profiles, but yes, I did have their introductions, but I will leave that to Dr. Apratim to take it forward in her style. So over to you, Dr. Apratim. You have 45 to 50 minutes for the session.
That in the morning it was red, so we all had to rush to change. So yes, I promise one thing, that for all that you have stayed back till now, I'll make it really interesting. So the panel is facial augmentation mastery. So first of all, as dermatologists or as aesthetic practitioners, we can never master it till we take help of plastic surgeons. So I have a plastic surgeon here in my panel. And secondly, when I was Googling what is the definition of augmentation, facial augmentation, it all said that increase. So, like breast augmentation and cheek augmentation. But I think we will go a little bit here and there, because at times to give a nicer shape to the face, we may have to reduce something, take in, a bit extend and all that. So that is where my panelists will help me. Now, Dr. Ashish. So, okay, can you guess why did I say anything to look hot, apart from the fact that you are the most dashing, handsome man here? So this was a book by one of your colleagues, Dr. Jas Kohli. It's actually a book available on Amazon, Anything to Look Hot. And this book actually states, his dilemma when he's doing breast augmentation and liposuction for females, how his female patients hit on him because he's good looking and stuff. So I would like to know from you, this is the picture I could get of yours. So has it ever been with you, Doc, the mic is there, that, with your, you don't have to name anyone, but has it been that people, your patients have flirted with you, hit on you?
Of course. It's part of our professional hazards, I suppose.
Anything which you would like to share?
About...
what happened, without names?
Oh my God. This is not part of augmentation, is it?
No.
Yeah. I mean, you can understand the time they take in the consultation,
yes,
and the questions that they tend to ask, and the way sometimes the questions keep going on and become irrelevant and more social. You can know that now, but I have a huge array of assistants and nurses all hovering around. They know the cue when to finish the consultation and finish it off right there and there. But it is a hazard that we have to face, I suppose. You have to face that too, don't you?
Yeah, but primarily this field is said to be female dominated. But I've always felt that if there are good looking, gracious, handsome, courteous men, then you can beat anyone. Because, your patients are females. And what better than having a nice, guy around you who treats you well, talks to you politely, So, and I think the best cosmetic surgeons, chefs, makeup artists, gynecologists in the world are men. So, yes, good looking guys. So, you know, we always have the ratio of in our dermatology post graduation, more females. And it was always thought that dermatology or aesthetic practice is more of females. But actually, I think if there are men like you, doc, then it's a clear winner.
Well, I don't know whether that translates into footfalls in the clinic. I'm not seeing much of that in Pune, but probably in Mumbai, Delhi, maybe it would have been different. I don't know.
So I have, I won't name the guy, but I have a cosmetic surgeon, like a plastic surgeon friend in Sydney. So he had put up his, like how typical doctor's picture on the website. And once we met and he said, you know, I don't get much patience. Then what he did, I think what he told me was that he was a gay, and then he took some pictures in the garden, casual pictures with his dog, you know, with wearing a shirt and all. And he said the moment I uploaded that on the website, long line of female patients. Yeah, everybody, it's a feel good, right? That's why we all are here. And everyone wants to feel good around a good looking person.
So is that a hint? Is that a hint I should be doing?
It's a hint that you are at the right place at the right time. So, yes, so welcome, Doc. Okay, Dr. Chiranjeev Chhabra, my next panelist. She's a dog mom, cat mom. She is absolutely a dog lover. I have 4 dogs too, and today is one dog's birthday. So actually, yeah, we have a big celebration at home. And for that, I went home in between the 2 sessions because we had to do some balloons and stuff. So yes, so this is Chiranjeev. Apart from the fact that she runs a successful chain of clinics in Delhi and Chandigarh, am I right? Delhi and Chandigarh. Very, very successful. She has, her patients cannot be named here, but she has who's who coming to her. I don't know how you handle that stress, honestly, Chiranjeev, but it's very stressful. So, Dr. Sonia, here, the one birthday girl. So, yes. Yeah. She has a little bit of white. So, she is living her childhood dream now. So, she is learning dance. Which dance is it, Sonia? Is it classical, Bollywood, hip-hop? Jazz. Oh, she's learning jazz. So when I asked her, they tell me something which I don't know about you. She's like, you know, I'm just, something which I missed in my childhood is what I'm doing now. So she's learning, this is her yesterday's picture when she was learning dance. And then the young, she also said that she's inspired by me. Because I'm also trying to do that. So then Dr. Soma, I had to put this one glam picture of yours. You know, she did a photo shoot somewhere and oh my God. You know, whenever I feel kind of low or feel bloated, I have to look at Soma's pictures. But I did not know that you are a Bharatnatyam dancer and you also write poems. Of course, comes from your Bengali genes, but yes. So welcome all of you, and now serious work. So, you know, Doc, I'm going to give you some questions and some cases, but I'm sure that we all, should we just turn your face, I think Dr. Ashish and Chiranjeev can move behind. Yeah. So I'm sure that, you know, you all have your own way of managing the cases. And, you know, having Dr. Ashish in the panel, I think a lot of surgical options would be available, but we want to just restrict to neurotoxins, fillers, threads, and at most extend to fat grafting, because that is what most of the audience would be interested in. So the facial augmentation tools, I feel, with people like us, is today the various fillers, the neurotoxin, threads, fat grafting, if some of you are doing, and mesolipolysis. And maybe you can use some lasers also to do that. Now, this is one case. So his concern was laugh lines. Maybe we can you just switch off those lights? All the lights. Because you can't see pictures and you... Band kar dijiye ye wali. You can't see her, it's not fun. Okay, so his concern was laugh lines. Now these are a different kind of laugh lines. These are static lines. And so anyways, I would like to ask my panel that what should be the first treatment, because how much ever I see that there is frown lines, there are other things, but he kept repeating This is my concern. So what would you do, Dr. Ashish? What would be your, only the laugh line treatment?
So basically, we have to first try to determine why he has these laugh lines or nasolabial folds. Now, they happen because of two reasons. One is, of course, there is a little bit of volume loss there, but it is also laxity or sag that is happening from the cheek area, which descends ventromedially, and that causes the nasolabial folds to become prominent. So in clinic, one should move the skin up, do a cheek lift, and see
How
if
would
it's
we do a cheek lift? With what?
manually with
You
as a
mean
clinical test.
to ascertain the...
Ascertain,
Okay,
yeah, to do
okay.
that and see whether the nasolabial lines are reducing by lifting the cheek up. There are people who have very stiff and very taut skin, and in those cases it's mostly volume loss, and those you would obviously treat by volume augmentation.
No, doc, but here, see, if you
So
think
here-
of fillers,
Yeah.
in this case, I'm not sure.
So that's what I'm saying, is that he probably would be positive for that cheek lift test. And if it is, then he's more a candidate for a mid-facelift or a facelift procedure or threads or something
Okay.
like that.
Chiranjeev?
So I am not a plastic surgeon. I wouldn't do a surgical facelift. But yes, seeing that there is loose skin, there is some amount of fat loss, and I would go in for thread lift. And after doing thread lift, maybe after a few weeks, doing some fillers.
Okay, so thread lift, right?
Yeah.
Which threads?
I would do PDO threads, and then there is PLA CL also.
Means cogs.
Cogs,
PDO
yeah.
thread,
Yeah,
cogs,
cog
threads.
threads.
How many threads would you put on to kind of give some improvement on the laugh lines with this gentleman?
6 on each side.
6 on each side. So that is important. You know, for those of you who inject threads, it's like 1 or 2 threads won't do well. The patient will have a lot of downtime, so it is best that you do. So 12 threads is what you are saying.
Yeah, minimum.
Yeah? Okay. And after threads, when would you think of doing anything else? Like whatever, a fractional laser or a filler, when?
After 3 weeks, I would do a fractional laser and filler. Maybe
Okay.
if I do a fractional laser first and next week do the fillers.
Soma, anything different than threads?
No, I think I agree with Dr. Chiranjeev that we would do threads. Obviously, we have options like PDO threads. We have PLCL now. We have Aptos threads. So whatever suits the budget also of the patient. Apart from that, yes, if I gauge the patient age somewhere, it's 50,
Yeah.
around
correct.
50 plus, so your
49
bone
or 50.
resorption is already started.
Yeah.
So after the lifting, the pyriform fossa will definitely require a little bit of filler there.
You
Along-
will also put 12 threads, Soma?
Yes, I would put 6 threads, but I would keep 4 threads for the mid face and take the rest 2 of the threads below the jawline, as in at the lower face.
Okay.
So to give me a better traction.
Okay.
Also, I will, as I said, that we'll do the fillers on the pyriform fossa and certain amount of fillers on the folds which are remaining after this. Overall,
Which
yeah.
will that filler be?
The filler has to be a little with a higher viscoelastic property, which will expand the lines, something. But on the pyriform fossa, it should be something which will give volume based. So a little
All right.
more hygroscopic.
All right.
And apart
if-
from that, overall, obviously with lasers, we can also do a bit of biostimulators. We can introduce biostimulators, or we can introduce boosters, or nowadays what we are talking about, PDRNs.
PDRNs, yeah.
Yeah.
Okay.
So these are the options we can look
so
at
this
it.
PDRN you will do on the line or you will do around?
No, I would do all around.
Around? All
yeah,
around?
Yeah,
Oh.
all around the
All
PDRN,
right.
I would all.
So PDRN was the product that we discussed in the morning also, polydeoxyribonucleotide. It's like a viscous material, and I don't know, I think morning panel was saying that they injected for pigmentation, but I don't know how much use is in pigmentation. I injected a lot on the lips when patient doesn't want fillers but still want the lines to go. Under eyes, crows. So I don't know, it's painful.
That's what I have. The first feedback from my patient with PDRN
No, that
was
is true. But
it's-
indication of PDRN, is it just a skin rejuvenation and fine lines, or it is also used for pigmentation? Because they said they use it for,
No, I have not used
I
for
don't see a
pigmentation.
logic.
No, I have not.
Dr. Sonia?
I've used in periorbital melanosis, the PDRN, and the first thing I saw was there was hydration and lightening.
Because of the stretch of the
Because
skin.
it has some amount of hyaluronic acid and some glutathione in it.
Yes, it
And
does.
plus it has the polynucleotides. So that stimulates collagen over a period of time. There are a lot of clients who come who don't want to go for a filler, and they just come with a little bit of hollowing, more of pigmentation and lot of wrinkling. So these are the subjects we choose for PDRN
Got
for the
it.
under eye.
Got it.
For
Dr.
the full
Sonia,
face,
what?
I was not very happy
With what?
with the full face PDRN. I was not very happy. Maybe just we just did one session of it.
Yes, please. Mike. Yeah, Sonia. Dr. Sonia.
Chiranjeev, those 6 threads that you mentioned, are they anchored or they're free floating? Which ones would?
I'm talking about free floating threads, 6 on each side.
Dog, we don't do anchored threads. Most of the times.
No, but I
We
think,
only. Huh?
please understand. Yeah, what we are speaking
Yes,
is
so.
cork threads, which would more be anchored because of the, barbed
Yeah,
one.
but
So they would.
No, but Soma,
obviously-
anchored means you
Yeah, we
stitch it
don't-
up with
no,
the
no,
fascia.
no, we
right,
don't.
dog?
That's what we are using. So we are using the bidirectional ones.
But
only.
both the ends are left loose. So,
Yeah.
okay. So, Soma, just for glabellar line, how many units for glabella?
So glabellar lines, yes, we have to have 2 actually, if you ask
No,
me.
I just need a number.
Toxin.
Number,
For the
yeah,
toxin,
yeah.
I would use somewhere around 6
That's it?
unit to 8 units.
Chiranjeev?
On the process, but with
I would use minimum 35 units.
Yeah, okay. I would use 24, but Dr. Son,
24, I
24? 24.
With
6
including
is way too
corrugators.
low, girl. He's a
no,
guy.
I was just talking about the process, but with corrugators, obviously it is going to go up.
Glabella.
His muscle mass is pretty good, and when you
Yes, yes.
palpate it, you'll realize that. And I would say do 30 and maybe keep 10 for the next visit, because after 10-15 days, he'll come and he'll definitely complain.
Yeah.
So it will land up to 35 to 40.
Why do I see that the Delhi doses of toxin are much higher than Mumbai doses? Why are we such pattus?
Because we are more stressed in Delhi.
No, we deal with a lot of, all the television media more. So it's very stressful because it shows. Yeah.
Delhi is more affording, I think.
Yeah, that is the point. That is very well
I
said.
don't think that's based on research.
No, that is based on people who have practiced in Delhi and Mumbai.
Maybe in Delhi they spend more. Maybe Mumbai they have more.
No doubt. It could be the financial capital, but they don't want to spend. Okay, so with the one of the CO2 resurfacing and threads, what you said, this is what we could achieve.
That's amazing.
Thank you. And these are the pictures in between. And he was very persistent. I want my laugh line to go. So in trying to do that, we did everything for him.
How many threads?
Sorry?
How many threads?
I did only 6. 3 and 3. This is an older patient.
A very good result.
No, but it's a combination. All right. So I will come to Chiranjeev. Chiranjeev, DAO, depressor anguli oris muscle, which pulls the angle of the mouth down. Now, a lot of injectors, senior injectors like you experience, they have a bit of concern for injecting DAO. I want to know your experience, yes or no?
Yes, of course. But then I would be very careful where I'm injecting. I would be more inferior.
Inferior?
Yeah, more inferior,
Towards
more
the
lateral.
mandibular border?
Towards the mandibular border, just half centimeter above. And more lateral, going in line with the nasolabial fold, like you just extend it downwards where it cuts the jawline.
Okay.
And then suppose it is associated with some neck folds, then I would even tackle the neck folds together.
So it's a yes for you?
Yes, of
and
course.
any average number of units you inject?
Not too much, 2 to 3 units on each
2
side.
to 3 units with 2.5 dilution.
Yeah, I normally use 2 cc dilution.
Okay. Soma, same? Okay. But you inject. Is it a yes or a no? Dr. Sonia? Yes. Dr.
0.5 dilution.
I think I'm the
But
one.
I have had experiences where it's really gone wrongly because
That's the thing.
because the toxin has diffused medially towards the DLI And the lip has gone up on that side, and trust me, it was a nightmare. I lost that patient. Lost means the patient didn't want to come back to me again. And
So how did you manage? Please, because we've all had those experiences. Because people read on internet, it can be treated with Botox, and
see, it gives dynamically the smile goes for a toss. It looks really bad. One where you actually knock off the DLI, the lip goes upwards on that side. So it takes time for it to diffuse. Like, you'll have to keep explaining. I explain to my patient that it'll ultimately go away. There's a lot of hand holding, but I know that it'll take at least 4 to 6 weeks, at least, if not more. So just to keep the person engaged, I'll call them back again to the clinic. चलो थोड़ा सा ultrasonic कर देते हैं, थोड़ा सा कुछ कर देते हैं, कोई RF कर देते हैं. But I don't know whether that really helps.
एक पेशेंट ने मुझे बोला कि ठीक है, आप दूसरी साइड का भी नॉक ऑफ कर दो.
हाँ, उड़ा दो.
लेकिन वो कभी नहीं उड़ता. जब आप कोई गलती करने जाओ ना, तो वो नहीं होती.
हाँ.
I tried a lot, लेकिन नहीं हुआ.
मेरे पास भेज देना.
So, anyways, DO is not for beginners, please. It is just 2 units. It's not even a lot of units. I think beginning should always be glabella or forehead. This means upper face should be the beginning. Lower face, I think platysma and masseters are relatively safe. Around the mouth, it's a disaster.
The perioral muscles are very tiny, and they are very small in size and very unforgiving where toxin is concerned.
And they are very overlapping.
Yeah, overlapping, you know, they cross each other, and you have to be very precise as far as the depth is concerned.
Chiranjeev, keep the mic with you. Nose fillers. Yes or no?
Very scared to do, but yes,
no, but you do.
Yeah, I do, but I'm very scared when I'm doing it. Earlier I used to do it. Now I even started doing it with a needle.
Okay, so if it is, sorry, not lip filler. If it is yes, then is it a cannula or a needle?
In the beginning, I used to just use the cannula. Now I'm using the needle, especially to fill this area of the hump if there is a depression here.
So you go vertically or you slide the needle?
I go vertically on the superior part of the dorsum of the nose, but if I'm injecting in the inferior part of the dorsum of the nose, I prefer to use the cannula.
Oh, okay. Dr. Ashish, nose fillers, yes or no?
Yes.
Okay.
Quite a big part of my practice as well.
Okay.
So I use cannula and
Entry?
from the tip, yeah, both the directions, even the columella and on the dorsum.
Okay. Now, is it true? I have seen a lot of, I have never done a single nose filler in my life, but I have seen patients who come and they're like, wow, and then in 2-3 days the filler goes and the nose, whole bridge of the nose becomes broad. Is it the wrong filler or is
the wrong filler?
The reality?
No, it's the wrong filler.
So it stays like this?
Yeah, you need a filler with a high G prime. Plus, you have to look at the patient's skin elasticity. I mean, the taut, tight skin patients, you're going to have a difficulty in getting a softer filler to retain. It's going to get squashed. So
younger faces
would obviously need a higher G prime.
Okay.
The softer, or if you can pinch the skin, then those are the candidates in whom you would be able to place the filler on, and it will stay.
Okay.
Yeah.
This seems to be a very dangerous area, vascular wise.
Yeah, obviously you have to aspirate before you inject.
Okay.
And it's the plane. It's just subdermal. I mean, it's a plane of least resistance when you pass the cannula. So it's that subcutaneous plane where you would be, maybe we call it just below the Scarpa's layer. So it just glides underneath.
There isn't resistance there in that
You will have to manipulate. There will be a path where you can go. So you have to get into that plane. Once you're into that plane, then the cannula glides through. Yes.
And you inject while withdrawing?
Yes, obviously, yeah.
Soma, you do nose? You also do nose? Okay. And needle or cannula?
I use needle with a
Needle?
Yes.
Even for the tip?
Yes. So I decant the fillers in the insulin syringe when I'm doing the tip. And for the bridge, I use the regular filler syringe. So I normally decant it into a thinner needle, insulin syringe, while doing the tip here at the base.
What is your level of injection?
So it's again submucosa. On this area, it's on the bone. The bridge, it's on the bone. You touch the bone, aspirate, and then you put. And I basically use small aliquots and then I merge it.
Wow. Dr.
The lower
Sonia?
area you do on in the submucosal.
Yes.
Dr. Sonia, you
I have
inject?
done on the periosteum, especially the
Cannula or
bridge.
needle?
Needle.
Needle?
Yeah.
All right. Next, Dr. Ashish, lip fillers, cannula or needle? Lip fillers.
I prefer the cannula.
Cannula?
I prefer the cannula.
What gauge?
25.
25 gauge.
Yeah.
Chiranjeev,
fine.
lip?
I do both with needle and cannula, but more so with needle. And but I have used cannula in the lip tissue as well as when I'm doing lips. I also do it in the perioral region superiorly. So that is where so that holds the lip from above. But I prefer to use a needle. I feel the shape is more
Exact. It's
I'm
more
into
precise.
it.
Cannula or needle?
I have used needle more. Cannula, yes, only when my patients have certain social gatherings very nearby and I don't want to bruise them. That's where I have decided.
Otherwise,
but otherwise
needle.
it's always needle.
Dr. Sonia?
Needle.
Needle. Okay. Now, now here I put up this slide. So this is what we had injected her. I have never used cannula for lip. There was one lady, a British lady, who insisted to use cannula. I did, but I wasn't happy with my results. So anyway, that's my thing. So I wanted to know that I'm sure you all read on Instagram, Russian lips, pumpkin lips, designer lips, etc. So is there something that is influencing your practice? Are you imbibing some of that into your injections, Chiranjeev or?
On reading about the Russian lip, I did the Russian lip technique with the needle on a patient, and I ended up with getting blebs at the distal end where the needle, at the vermilion margin.
At the,
Yeah, so I went back to doing it by the cannula. So
All
I'm
right.
better off there, I think.
All right, Chiranjeev, anything specific? Give one tip to my audience, please.
So I find that people want voluptuous lips. They want attractive looks. They want to look different, and especially the younger generation. Now even till 50 girls are young. So, or even 60 or whatever.
So Russian lips or no?
So I do a special technique called sweetheart lips, which is which I have devised myself. A sweetheart lips.
Okay, so you put.
So I make a heart. I make in this I make a heart in the upper lip and a heart in the lower lip, and actually the lips become very voluptuous and shapely. And how I started doing this about 6-7 years back is that I used to do lips for young girls, and I was doing actually for my own daughter, and she never used to like it. She used to like it, but it was okay, like. Then one day I realized I'm not doing something correct. There's no oomph factor to it. So then I studied anatomy, I studied art, I studied how these artists or these sculptures do the lips, and I realized that there is if you see the lip very closely, there are certain curves on the lips which, if you look with undivided attention, looks like a heart, a superior heart fitting into an inferior heart. And that's how I devised this technique.
So that's a bolus technique, or you are threading it also?
I'm threading it also.
Okay.
It's a threading technique.
Okay. Any particular, your designer technique for lips?
I follow basically presentation of the lips, basically, because not all lips are same
Do
all
you,
the time.
simple to put, do you go vertical?
So I do vertical struts, which is also known as actually the Bombay technique for a very long time. Yes.
Really?
Yeah.
I thought that's
So-
a Russian cross.
So that's what I do, but when I see very thin lips, when I have to evert it. But when I have to volumize, I normally go with my thread technique. And I always believe less is more.
Sure, we've heard that. Yes, Dr.
Yeah,
Sonia?
so generally they come and ask for it, that they want those 2 tubercles on both the sides. So we
So-
take a rubber band.
So does that
and ask them
influence
to
your
hold.
practice? You do
It
that?
does, it does.
It
Yeah.
does.
Only when they ask for it,
Yeah.
something specific. Or they bring pictures to me that I
Right,
want this kind
right.
of lips.
Lovely, thank you. So lip filler. This is another one of, okay. Now technique we have discussed, lip filler, we can move. Under eye filler. I think one thing which is still a scare. So Dr. Sonia, under eye filler, yes or
I
no?
prefer cannula.
One, you prefer cannula and the answer is yes. You would do. Soma.
I would do the needle. I use
Needle?
needle under eyes. Yes. Mostly under eyes, only cannula for medial portion at some
And if there
times.
is a choice for a patient between doing lip and under eye, which one will you prefer?
It's a tough question though.
Both?
I would like to do both. Yes. So yes, sometimes both, and most of the time it's under eyes.
Yeah?
Yeah.
Confidence.
I use cannula only in the under area. I am too scared to use the needle. I don't understand the concept of
Same.
using a needle.
Yeah.
And if I had the option of doing under eye or lips, if I have just 1 ml, I'll do lips. If I have at least 2 ml, then I'll do the under eyes.
What? 1 minute. You will do 2 ml for under eye?
Huh?
Means under eye and lip.
No. See, when I'm doing the under eye, it's actually not just the under eye. We are also doing the mid of the cheek, the support inferiorly. Na? So at least 1 ml on each side.
Okay. And what cannula size?
I use 25 and 23 both.
23 as well?
No, for the under eye, 25.
All right. Dr. Ashish? Yes.
As Chiranjeev said, you do need some support in the mid-cheek area, and I prefer to do that with a needle.
Needle.
So I would use pillars, CK4 or CK3, those areas, and then I would use the cannula and do the tear trough going into the sufac pad area.
The filler will be different with the...
Both would be different, correct?
Both
Yes,
fillers will
yes.
be
So for SUF, it would be a softer filler.
All right. Now, Dr. Ashish, what is the maximum amount of toxin as well as filler which you have injected in one patient in one go?
Toxin-wise, it depends on the requirement, but it could go up to 60 or maybe 80 units max.
Filler?
Filler-wise, I would love to inject more, but I mean, it's rarely more than six syringes or thereabouts.
All right. 6. Chiranjeev, maximum record?
Maximum toxin I've injected is about 120. I'm doing
Including
the masseters,
platysma?
including masseters.
Including masseters.
And maximum fillers I've injected is 15 ml in a face.
On the face? One go?
One go. Just before yesterday only I did it.
That's why I said, see, Delhi people, rich people.
No, I mean, you see a lot of very women who come to me are in the older age bracket where they need a lot of work. And there are a lot of women who just want to come and see my face once in a year. And they tell me, I'm just coming once and now I'm going to come exactly after 12 months. So whatever you have to do, you do today only.
Chiranjeev, when you are typically consulting a patient and she says that, okay, I'll do the filler, but how long will it last? Do you have an answer for that?
Yeah, I tell them a little story that normally the companies say 1.5 years, but I've seen it lasting well till 1 year. But again, I also tell them that if I put the full dose, say if I'm telling her that the full dose for mid-face is 4 ml or 6 ml or 8 ml, whatever is the full dose, if you put the full dose, it is going to last. But suppose I have suggested you 6 ml and you're just doing 2 ml, then it's going to last you maybe after 6-8 months, you will need to come back to me for sort of a touch-up or something. How I explain is, like I tell them, if there's a very big boulder at the base of a big mountain and some water is coming from top, the water can't push the very big boulder away, but if there's just gravel, then your own circulation will push away the small bits of filler that I have distributed all over your face. So I tell them averagely 1 year.
All right. But there are now MRI studies which are done and which show that the filler lasts for 8 to 10 years also.
Yeah, that's true.
And we've seen that in practice, especially under eye, a very scary area for me. Because sometimes the patient says, yeah, I injected in like 2008 and there is a blob of filler sitting.
No, I do agree with you, but then if I can't commit that to the patient, otherwise...
I get it, completely get it, but all right. So next question now, let's concentrate on the forehead because her concern was just forehead. So what should be the dosage of toxin to take away this little frown which she has in the glabellar area? Soma?
Isn't the complete upper forehead with the glabular lines and everything together?
No, not forehead. Glabella, let's say.
Only the glabular lines.
Glabella means both procerus and
almost
corrugator.
30 units.
And how much?
30.
30?
Yeah.
You just upped your dosage from that guy to this girl. Yeah, so she also has a broad corrugator, as you see. What, Chiranjeev, what will you inject? How many units?
In the glabella, I'll inject something like 20 units.
Okay.
And if I upper forehead, about 8-10 units.
Dr. Sonia, same or different?
I would go slowly, like I'll put about 15 to 16 units first and call
15
them
to
back.
16.
Yeah.
No, I was just talking
Only
about
glabella.
glabella. All right. So now, Dr. Ashish, the dosage for, though I think when I was putting this picture, I thought I have only one brow up and one brow down. So please ignore that. Now, the dosage for only glabella. In fact, forehead has not been done.
So she has strong glabellar muscles, but I'd
Yes.
still start with, if this is the first time I'm injecting, I would still start with 8 units each side.
8 corrugator and 8 corrugator.
Correct, on each
And what
side of the-
about the center muscle?
I can't see the transverse line there, but yeah, otherwise 4 units in the middle, if that's a prominent line as well.
So
for the
8,
procedure.
8 and 4 would be 20.
It will be 20 units to start off with and see the response in 2 weeks' time. If she's happy with it, then continue in the same way. Otherwise, add some more units.
Chiranjeev, anything different?
I would do 20 units.
You would do 20 total?
Total in the glabella.
Okay.
Upper forehead seems fine.
No, upper forehead
What?
was not even
20,
injected.
but I normally, I just share with you that I normally call my patient back after about 15 days and I touch up the patient free of charge.
Oh. But you inject only a good dosage in the beginning. So nothing probably is needed at the touch-up.
No, you always, I think sometimes you need to fine tune something, fine balance something.
But that's a good trick to get a post picture. Because you know, when I was going through my folder, I hardly have post pictures. Pre, I have everybody.
So call them back after 15 days and say it's free of charge. Bill them in the beginning only.
All right. So now here, we of course did a HIFU here, only HIFU that was fitting in the budget. Now I have a question for all of you, and please tell me, you see this eye roll, right? Lower eyelid. Let's not focus on anything else on the face. I don't even know if I have spoiled or made better, but this is where we get stuck, right? This. What do we do, Dr. Ashish? This under eye kind of roll.
See, when I look at her, I see a little bit of periorbital volume loss, or else she has got a little bit of proptosis, because her the whites of her eye are visible. So we need a lateral view to see exactly what's happening there. She could be having a negative vector eye, which means that her cornea is in front of her cheek. So if that's the case, then she needs to have augmentation. I would consider her for filling in that area, especially the SOOF and the roof fat pad.
This area, where do we fill? In this
Yes,
area?
yeah, down
So,
below.
so
Yeah.
basically she is a candidate for filler, under eye
Yes.
filler.
Yeah, definitely.
I don't know. Chiranjeev, what do you do?
What I see is that there is hollowness, plus the quality of the skin is very crepey. And yes, she is a candidate for fillers, but but beyond a certain amount, her hollows will be filled up, but the crepiness will look more prominent. Maybe the darkness may just look more prominent. So I would also do a fractional laser for her.
Fractional laser,
Yeah.
like a CO2 or a
For
erbium?
erbium fractional.
Erbium fraction. Erbium glass or erbium YAG?
Erbium, yeah.
YAG. Okay.
Yeah.
2940.
Minimally ablative.
Got it. So, okay. So you would do that in the same session, right?
Yeah, I can do it in the
Yeah?
same session.
Yeah. Soma, anything different? You said something PDR and Soma. Did you? Or
Yes, I
heard?
would like to, but I just also felt that she has a little pseudoacanthosis.
She has what?
Pseudoacanthosis in that area, looking at the crepiness very close to the lower eyelid.
No, that must be the light.
Probably. So
She just
also,
has laxity with a bit of edema, lines, wrinkles.
I would not mind also giving around 1 unit of toxins
Yeah, Chiranjeev, have you
on
done
her
that? There is a
lateral
lot of
lower
Instagram
area.
fad of putting hair.
not medially, lateral.
So the thing is that I have given inferiorly just below the eyelid 1 to 2 millimeter away, or 1/2 unit of toxin. But you know what I see, that there is this whiteness around her just above her upper eyelids, which means that either the laxity of the lower eyelid is a little bit more and the eyelid is falling downwards. So I'll do a pinch test to see if there's enough elasticity, only then I'll give her.
But you would do 1 unit of toxin on
Yeah, I would if
inferior.
if the tissue is elastic enough.
Where would you put?
Here.
Yeah, here, just where she's showing. 1 millimeter, no, little bit lateral to it.
Yeah.
Center of the lower eyelid, 1 millimeter inferior. Here somewhere.
That's a maximum balance. Yeah. Has
Yeah.
everybody understood? Otherwise you will hear a loud noise.
So this is basically trending on Insta right now. It's called
Yes.
sausage roll. It's the
Yeah.
hypertrophic pretarsal plate of the orbicularis.
Absolutely nailed it, Dr. Sonia. Do you inject this with toxin?
Toxin, I tell them the risk and then do it. And the other one, she's a candidate for PDRN.
Yeah, the ribonucleotides. So PDRN, you keep saying, what is the needle size that you injected with and how close to the eye do you go with PDRN?
You use a 30 gauge insulin syringe. You have to dilute it. And then you can use a 5 or 6 point technique. Stretch the eyelid down and then put your point, just like how you do PRP, intradermal.
Yeah.
I'd like to ask you, what in PDRN is going to help the skin around the eyes?
Hyaluronic acid?
Yes,
Yeah.
so we are calling it PDRN, but actually it's hyaluronic acid.
No, no,
the
but there is
instant
gluta,
result.
PDRN, gluta and PDRN and
And
HA.
non-linked HA.
Non-cross-linked.
Non-cross-linked HA. So it's the non-cross-linked HA which is helping,
Yeah.
not the polynucleotides.
That's the
We don't know,
immediate
it's
result.
too early.
That's the immediate result.
Yeah, that is true. That's the immediate result. You get a stretch and you get an improvement. For example, if somebody came to you, not this one, but somebody came to you with lips that I don't want filler, but I don't like these little lines where my lipstick kind of sits. What will you do?
Skin
Chiranjeev?
boosters.
So this is like skin booster.
It has got about, 18, 12 milligrams of HA.
Like a Vital.
Yeah, like a Vital.
Vital or Volite is what you would do.
Volite is 12. No, I have even done PDRN, means just 1 or 2 cases for the lips, but I've done lots of boosters.
Chiranjeev, my experience, I don't know about others, is that your boosters, they tend to clump. And in a lot of my cases, even for 4 months, those blebs have not gone. So, and with PDRN, I would have done some 30, 32 patients so far. Not even a single case where whether we put on the neck lines or we put on the lip lines or we put close to this little crappy lines, no clumping, no nodular formation.
That's because it's not cross-linked.
Yeah, correct. But then, maybe
And
we
plus
don't
it's
need...
5 milligram HA.
I think so, yeah. So, and it's a very easy
Yeah.
product. It's only thing is company says that for under eye and lips you dilute it. I don't dilute it.
I also haven't diluted.
Yeah, but I think it's...
They haven't told me to dilute.
Yeah, they got scared of you. And plus I told you, again, Delhi patients. What did I say? Delhi patients are rich.
They have thicker skin.
So, yes, okay. Now, Dr. Ashish, see, this is the lateral. I didn't even remember that I had it. But we did HIFU, and you know what? I like to do HIFU here also. Yeah, I like to do HIFU. Sometimes it helps with under eye bags also. I even do 3 and 4.5. Soma, if I can, get the bone there and kind of place it. So, Chiranjeev, what would you do, Chiranjeev? Let's say, now this is a fresh case.
It's a very difficult case to treat for me.
You would refer to us, Dr.
Yeah, I would refer to you.
Dr. Ashish, I put up this specifically to ask you if she is a case of blepharoplasty.
Yeah, certainly. So she does need volume along with just a blepharoplasty, and I would
Okay.
consider fat grafting.
Okay.
And then do a blepharoplasty, appropriate blepharoplasty, like either a pinch blepharoplasty and a little bit of orbicularis suspension, so that her the orbicularis is suspended. Along with that, a malar fat pad is also suspended.
Right. But does the audience appreciate the result of HIFU? We did HIFU till here, but this whole area. So it kind of got, I think right now we are lost in the eye, but please appreciate the result of jawline also. Yes, Chiranjeev, you were saying
You know
something.
what I think is that there is an element of insulin resistance here. Because just see the
That's
color.
what even Soma was saying, no,
A
just now.
perioral pigmentation slightly, around the eyes slightly. So we need to treat her medically. I mean, we need to investigate and treat medically.
Could be, yeah. Now this patient, I want to know from all my panelists, because there are a lot of cases where people are not happy with their jawline. They want more Deepika Padukone jawline, right? And so everybody, of course, we have a choice of needles and cannulas and etc. So what is your USP for, I don't know, I like to do a toxin in Mentalis before I inject because I feel it's easy, but that could be me. And we've just injected like 2 ml filler. We injected lift with a cannula, Restylane lift. But Chiranjeev, anything different, Dr. Ashish?
Well, I would suggest a facelift to her.
Facelift?
Yeah.
Is she a candidate here?
Yeah,
Because she asked me.
she's got
I said,
nasolabial lines, she's got marionette lines, she's got a jowl. And if you tested the malar skin or the cheek, it would easily move back fairly significantly and correct all of that.
yeah,
So
she
that
has
is what
a
she
malar
needs. Yeah.
protrusion for
It
a
sagged
long,
down
long
as
time.
well. You can see that there's deflation in the malar fat pad, it's come down.
Yes.
And all of that needs to get lifted up, which it would correct all the problems then, once and for all.
Okay. Dr. Chiranjeev?
Yeah, I think there's a lot of improvement starting from the neck upwards, jawline, lips, cheeks. I think there's a lot of improvement. She's looking like a different person. I would
you.
You're showing your best pictures, I think, purposely.
Yeah, we all do that.
So I would do fillers, and yes, I would maybe combine, if she's wants more results, then maybe combine with threads. I would start with fillers, and maybe after 2-3
Okay.
months think of doing threads.
You would start with fillers and
Yeah,
go to
it's
threads.
easier.
Correct.
And plus, he's saying that he would suggest her surgery, yes. But the thing is that
Patient should be
sometimes patients don't take the surgery.
Most of the times they don't.
So if they refuse surgery and want something, then obviously fillers and threads are the only alternative,
Right.
and HIFU as well. But
Right.
my question to you is, did you only inject along the jawline, or have you injected anywhere
No,
above?
we've done lip, we've done nasolabial.
No, I mean to say anything on the zygoma.
No,
Nothing there.
No, nothing on this.
Okay. I mean, she's
no,
heavy.
not
She's heavy, but
injected.
without that, you're not going to get a lift.
No, we did a HIFU first. I am a HIFU person. So I do a lot of HIFUs. HIFU is usually a first treatment which we do for patients. So we did HIFU, and then we did 2 ml of filler and 1 ml for lip.
Because she has a little bit of pre-jowl area, a little fullness here on this side, on the
That
lateral
is the
side.
one, no? With
Yeah.
cannula, yeah.
No,
this
so you have done the jawline, but above that, if you could see the little bulge. So would a thread, you did HIFU, but would just
yeah, thread
two
would have
threads.
been a choice.
Yeah, and then obviously fillers is required to make
I
the
keep
jawline.
thread as last and HIFU as first, and the remaining in between. Dr. Sonia, anything which you would do
Yeah, I would
differently?
address her volume loss mid-phase first.
Mid-phase?
Mid-phase, like she see
Yeah,
the
the
lateral area?
pre-tragal area, no?
The
If you could just
pre-auricular area.
put a little viscoelastic filler
Yeah,
somewhere.
and she
just
has
to
a
give
lot of
little-
laxity, which I would address after addressing the volume loss. And lastly, I would then look at her jawline. Energy-based device, yes, of course, comes first.
Yeah, HIFU or
HIFU,
RF.
Yeah, HIFU.
HIFU, okay. So many times the concern is heavy face. And then when we see heavy face, there are two things which make a face heavy. One is the buccal fat, the lower face fat, and second is the under chin fat. So I don't know what is you guys USP to deal, because we get a lot of requests for heavy lower faces in youngsters. Dr. Ashish?
So I would look at the 3/4 view to see where her malar fullness is and whether that is giving her a nice OG curve or not. Otherwise, putting a high G prime filler there and along the zygoma would be one way of lifting, and also giving her the triangle, this.
How will we remove this? Because this
Yeah,
is
so
what
after doing all of that, or if you, after discussing with the patient, agree that the buccal fat pad is to be removed, then that
that's
would
what
be
I want
that
to
would
know.
be a surgical option that you would suggest to the patient.
Because we struggle a lot with this, no? Sometimes that
Yeah.
ball of fat there. Chiranjeev, how do you do such heavy faces?
So I would look for the masseter hypertrophy. If I do Botox, if it is there. I would do fillers in the preauricular region and at the gonial angle, just to lift this area up without making it broader.
Okay.
And yes, I would do HIFU.
Yeah?
Yeah.
In what order?
First HIFU.
First HIFU. Okay. Yeah, okay.
But tell me one thing, you're saying the buccal fat needs to be surgically removed. Have you ever used lipolytic solutions?
I have. That was my next question.
Acha.
The buccal fat pads. What is the choice? Surgery, HIFU is very slow, very non-specific. What about meso? I have done it, but I'm scared. Because it's not even FDA approved for buccal fat pad. It's FDA approved for your doctor.
There are just outside of the buccal fat pad, there are buccal nerves running underneath the fascia, which are closed. So if you are trying to enter into the buccal fat pad, you could easily get the phosphatidylcholine causing inflammation in buccal nerves.
Yeah, it did have a lot of swelling, but it worked. But I don't think my patients will take that downtime. So
if you do HIFU little extra in that area where there's extra buccal fat, will that help to dissolve it?
I have seen HIFU doesn't have that much lipolytic properties. I don't know. It's not, I don't know. What about Soma, anything? No, doctor?
With meso, maximum 2 sessions I do because they complain a lot of swelling, downtime.
So you inject here?
It is very painful also.
And with buccal nerves?
And I've seen some cases of granuloma also with that. With
Really?
mesolipolysis. Not here, but I've seen on the abdomen.
Yeah, it's not something.
We'll send the patient to him.
So that comes me to
After
my
charging him all the procedures, then the last thing we'll send to him.
So double chin. So the other thing which makes patient uncomfortable, makes the chin look smaller, make the lower face look bigger, wider, especially on pictures, is double chin. So what is the treatment modality for double chin for Dr. Sonia?
Double chin, again similar options. We have HIFU, then mesolipolysis.
So how do you
Threads.
do mesolipolysis?
Generally, I use the deoxycholate,
How? With the multiple puncture?
multiple puncture technique. Yeah.
Okay.
Maximum 4 ml per session.
Okay, maximum 4. Dr. Soma? Same?
I use injection lipolysis. I also use cryolipolysis, whatever fits in my bill and whatever the extent of fat. If it's too extreme, then cryolipolysis is a better option. If
Okay.
it's a small pocket of fat, then injection lipolysis is a better option. With multiple sessions, obviously you require. And after debulking, then I introduce my HIFU or an RF or threads to tighten up the overlying skin. Sometimes I also use a little bit of toxins on the bands so that this overall area looks better.
Correct.
Yeah.
Thank you. Yes, beautifully. Same?
Yeah, same thing.
Okay, Dr. Ashish, same?
So in my clinic, I see 2 kinds of patients. There are some people who have double chin because of retrognathia, because the chin is poorly developed. And obviously the others who have more fat or sometimes just laxity, platysmal laxity. So they may not have subcutaneous fat, but subplatysmal fat. So if the chin is retruded, you would obviously suggest a filler, augment the chin. If it is subcutaneous fat, then injection lipolysis is one option, HIFU is another, liposuction is there. But if it is subplatysmal, then needs a cervicoplasty. So we go in and take away the fat which is in between the digastric subplatysmally, and they do well.
Perfect. So, Chiranjeev, recently I had seen on one of the conferences somebody doing a fanning with a long cannula, 70 mm, just make a puncture under the bone, and then through one puncture, take that plane, you know when you are in the fat, and just distribute lots of deoxycholic acid alone or in combination, and the results were phenomenal.
Actually makes sense. I have not tried, I've just done with the needle, but it makes sense.
Because I used to do needle all the time, and apart from the pain and then multiple bruises, invariably lot of bruises. So I think just try this single technique, take a thicker cannula and just only through one entry point we can cover the entire pre-tarsal fat. So, yeah, needle is pretty traumatic. I think multiple needle is only for, I have not tried this technique in underarms, but I don't know, for toxin.
It's
Good suggestion.
Sorry?
It's a good suggestion.
same.
Now I use easily 10 ml, but earlier, like Dr. Sonia, I was using 4 ml. But I use 10 ml and, you know, just put a cold this thing and bandage. I have this, you know, you get these anti-snore pads on Amazon. So we have those. Just tie that and send the patient. Lot of cold compress, beautiful results.
Single session.
Yeah, you get, so just,
Single session, you get good results.
yeah, usually single बहुत heavy है तो double. Because now they don't want to go for a surgeon. So I tell them that this is a slow process. Okay, now comes the most tricky thing, which is neck horizontal static lines. There's one word solution from all my panelists.
Very difficult to treat, but the options are we use nanofat injection in there, but fillers is the alternative. You can inject intradermally, and it has to be a fine filler, very soft filler. Yeah.
Right.
I am using a combination of Profilo as well as skin boosters
Profilo
slash
to you are
fillers.
using at 5 point.
So what happens is that spreads under the skin and stretches the skin. It gives some kind of lateral support. And then if I have to go into the horizontal line, then I'll use a softer filler.
It doesn't clump and lump for months.
No, it doesn't. But I start, if I feel the skin is too thin, then I do use a skin booster instead of a filler.
Okay. Anything else?
Fillers, as rightly said, but the ones which has the lowest cohesivity, so which has more flowy, so that it doesn't form any clumps, and it can be really put, you can really put superficial. There are very few, if I can name them. One is known as Boletero Soft,
Yes.
which you can really go superficial and
Yes,
give that
yes.
blanching effect, which helps it in the neck lines.
So if you have to choose between a Bellatoro Soft and a PDRN, what will you choose?
I would still choose the Boletero Soft.
Really?
Yes.
Because more longer lasting.
Yes, more longer
Dr. Sonia,
lasting.
anything different than this?
I use a combination. I use the traditional Nefertiti for the necklines, and then I put in a Profilo. And into the necklines, I've tried using mono threads.
Acha.
Yeah, to
Threads.
build collagen. PDRN is, of course, recently.
I also
come,
have
so
done
haven't
it.
tried.
It gives good results.
Okay.
Lots of mono threads in the
Lots,
line.
no, 100 type, 100,
Yeah.
200 threads.
And not 100 to
It looks
100.
very fancy, you know.
No, not 100 to 100, just in relation to the line, in the depth of the line, yes. About
You think-
20 threads in
You
one
think
line.
threads help? I feel it's a placebo.
Which threads? Like the mono threads?
Mono.
I think that trauma creates some kind of a stimulation of collagen.
Okay. Yeah.
It's not like a wow result, I would say.
Yeah.
You can also combine it with CO2 fractionated laser overline.
Yeah. Yeah.
So that also helps in the creepiness of the neck.
Yes.
You have to combine. Neck is always a combination
Yeah,
treatment.
Yeah, it is. All right. So, audience, are there any questions which you would have for the panelists? We could probably take 1 or 2 questions. Anyone? How many here are injecting toxin? Like any toxin, but you are injecting? Quite a few people injecting toxin. Okay. And how many are doing fillers? Proper fillers? Wow. Quite. So have you started using PDRN? That the combination? It's like a forgiving filler type. To practice, I think one can always start using that. All right. So if there are no questions, I think it went as a fabulous panel discussion. And let's sum up with the group picture.
All thanks to you making it interesting.
Thank you so much. If there are any questions, you can always reach out to them or to me on Instagram. Yeah.
It's always
and
a
Dr.
fun session
Apratim-
with you, Apratim.
Sorry?
Always a fun
Thank
session.
you so much.
Yes.
Thank you. Let's take a picture.
I was just thinking, Dr. Apratim's session is incomplete if she does not talk about all our Instagram pages. So yes, Thank you so much, Dr. Apratim. You are fab as always. And the fab panel out here, Dr. Sonia, Dr. Soma, Dr. Chiranjeev, Dr. Ashish, thank you so much. Value your time. You'll have been with us all day. The group picture first, followed by a token of gratitude from our side to all of you. Ladies and gentlemen, a huge round of applause for them, please. That would be helpful. Thank you so much. So one more group picture with your mementos, and ladies and gentlemen, this brings us to the end of day one of the panel discussion. But the day is yet to end. All my esteemed speakers and delegates do join us for the director's reception at 6:30 p.m. at Nesco's Social, where we all are together for a meet, greet, networking, evening and dinner. This is only on invitation basis, so for those of you who have received the invitation, do join in and do join us. Also, do not forget to join us tomorrow. We will start sharp at 10:30 a.m. The day has been planned with an interesting lineup of workshops that will focus on building a successful clinic. We will be touching upon critical aspects of medico-legal, digitalization, clinic design, social media, public relations, how can you build a thriving team, and much more. These sessions will only back your entrepreneurial vision. So see you all tomorrow. Tomorrow all sessions are going to be at hall number 2, and I will look forward to meeting you all. Thank you so much.